Dr. Zamhariyah dah ready ke?
Mana?
Alright, okay. So I think we shall start. It's 8 o'clock now. So, okay, Bismillahirrahmanirrahim. Assalamualaikum and a very good morning to everyone. Welcome to our monthly CME hosted by Iium Family Health Clinic lah. So, let's start with Ummul Kitab Al-Fatihah. Zam dah sihat Boleh present Alright. Okay, so our CME topic today is on management of asthma in adult. I think the discussion will be focused on this latest CPG lah. Tak nampak Okay, so this latest CPG on focusing on adult, second edition launched last year. So Dr. Zamirah will be presented, our postgrad year 3 student. And then if you have any question, you can type in the chat box lah. So I think without further delay, please welcome Dr. Zamirah.
Thank you, Dr. Adi. I will share my presentation. So, Bismillahirrahmanirrahim. Assalamualaikum and a very good morning. So today I'm Dr. Zamhariyah, postgraduate student year 3, family medicine of Iium. Today I'm presenting on management of asthma in adult patient. So my presentation will be based on our local clinical practice guideline, management of asthma in adult, second edition, which is published in 2024 last year. This is my outline of presentation. Mainly will briefly cover on prevalence and burden of asthma in Malaysia. Then we proceed with how to diagnose and do assessment in asthmatic patient. The main core of presentation today will be on management of stable asthma and consideration in special population. So moving forward to prevalence of asthma, in Malaysia, it is estimated that there are about 1.6 to 2 million of asthmatic patients, and this number has been increasing over the years, as we can see from the graph above. So, however, there's undiagnosed asthma among adults about 3%. According to NHMS 2023, among adult in Malaysia that had been diagnosed with asthma, 22% of them are reported to have 1 to 3 asthma attack in the past 1 year, whereas about 8% of them reported of having 4 or more asthma attack in the past 1 year. Out of this, it's also mentioned over here that out of 10 patients, out of 10 adults, there's about 3 of them have not been diagnosed with asthma. So both overdiagnosis and underdiagnosis of asthma are common. This is mainly because of asthma symptoms are often subtle, leading to delays in diagnosis and proper treatment. And even locally and even globally, most physicians do not have timely access to spirometry. So how actually we can diagnose asthma? Is it asthma? Once the patient present to us, is it easy for us to diagnose asthma? Actually, for us to diagnose asthma, we must bring all the pieces together so that we can actually confidently say it is asthma. So we must get proper clinical history from the patient. We get the typical asthma symptom, and then we ask the patient whether she or he has any risk factor that can predispose for her to get asthma, any triggering factors that can cause or exacerbate the symptoms of asthma, and then we confirm the diagnosis of asthma by using investigation. So in asthma, there's no gold standard test to diagnose it. So that's why we must bring all the pieces together to diagnose the asthma. So what is essential to diagnose asthma? Basically, first we must get the typical asthma symptoms, and then we must get the evidence of variable airflow limitation so that we can confidently diagnose asthma. So as I mentioned just now, what are the clinical history and symptoms that we must ask the patient? First, we must get the whether the patient having common symptoms of asthma, whether they have wheezing, cough, any chest tightness or shortness of breath. And then we must elicit whether the symptoms is variable. The symptoms must be episodic in symptoms, or must is or the right it has diurnal symptoms, or the symptoms only occurs during or after exercise. What are the triggering factors that can cause asthma? For the patient, either it's common cold, any allergen, cold weather, or any irritants like smoke, haze, or strong smells from the perfumes or cleaning solution or exhaust fumes. Other risk factor that you must elicit from the patient himself, whether he got any history of atopy like allergic rhinitis or eczema, or any family history of atopy. So most of the patients usually come to us, we cannot elicit any physical findings unless they come during exacerbation. So during exacerbation, we can elicit whether there is any use of accessory muscles, any audible wheeze or rhonchi on auscultation. So what are the investigation that we can do to confirm the asthma? First, as I mentioned just now, we must get the typical history and physical examination. If it is consistent with asthma, we can proceed by performing spirometry. With broncho reversibility test. First, from the spirometry, if the value of forced expiratory volume in 1 second over forced vital capacity less than 0.7 or less than lower limit normal, so it is confirmed that this is an obstructive airway disease. So to diagnose asthma, we must get another confirmation is that we must get the positive bronchodilator reversibility test to confirm the diagnosis of asthma. If this uh, if this findings is not fulfilled, then we must consider further history, further evaluation and investigation, and consider other alternative diagnosis. So what are the investigation that we can help us to diagnose asthma? First, like I mentioned just now, is spirometry. And then for first from the spirometry, we can demonstrate the airway obstruction. Then for the demonstration of airway obstruction, variability or reversibility, usually is either following bronchodilator treatment or after 4 weeks on ICS. If we can see an improvement in FEV1 or FVC more or equals to 12% and more or equals to 200 mils following bronchodilator treatment. This is confirmed that the airway obstruction basically already reversed. If we are using ICS, we can see the same improvement. If But this must be a comparison from the patient baseline until after 4 weeks on ICS. The demonstration of airway variability or reversibility can also be done by using peak expiratory flow rate meter, in which we can see that there is more or equals to 20% improvement in PEFR following bronchodilator treatment. We must remember that before we proceed with this investigation, if you are using SABA, we must withhold the SABA at least about 12 to 24 hours before we proceed with this investigation. Or if we are using the LABA, we must withhold the LABA at least 48 to 72 hours before we proceed with this investigation. Okay. Other test that is available over here is broncho provocation test. In this test, there's a substance like methacholine or menthol powder introduced to patient to demonstrate that it can induce bronchoconstriction to the patient. Sorry. Um, there is also test to detect the type 2 high inflammation. This is usually a phenotyping assessment done usually in severe asthma, in which is include blood eosinophil, serum IgE level, and pheno or is whether we can demonstrate any elevated pheno level. So these tests, mainly the spirometry and PEFR, should be performed before we initiate the treatment, and at 3 to 6 months after treatment, and periodically 1 to 2 yearly, to establish patient personal best forced expiratory volume in 1 second and to monitor for lung function decline. A low FEV1 usually indicate underlying untreated AV inflammation. It is a risk factor for future exacerbation. So what are the assessment? Once we diagnose the patient with asthma, what are the assessment that we must take note to do for the asthmatic patient during a medical review? First, we must evaluate the current symptoms. The evaluation must be done using a validated questionnaire or tools to diagnose their uh, to evaluate their asthmatic control. And then we must see whether patient having future exacerbation risk, what are how they adhere to the current treatment, and we must test their inhaler technique. So the validated tools that we can use to assess the asthma control. The first one is GINA assessment. So if a patient having none of these symptoms, usually they are well controlled asthma. If they are having 1 to 2 of symptoms, they are basically having partly controlled asthma. And if they have more 3 to 4 of these symptoms, they have basically uncontrolled asthma. Another validated tools that we can use, usually in primary care, we can use the ACT test or asthma control test. These score, just like the GINA assessment just now, it have a score so that you can differentiate patient from well controlled to poorly controlled asthma. The score of ACT from 20 to 25, so the asthma control basically is well. If patient having 16 to 19 ACT score, the asthma control is partially controlled or moderately controlled. If patient having 5 to 15, mainly their asthma is poorly controlled. So what are the risk factor for future exacerbation? First one, if the patient having previous history of severe asthma exacerbation that requiring systemic corticosteroid or hospitalization within the past year, or any overuse of SABA, which is more patient have been using more or equals to 3 canister per year. Patient have using inadequate ICS use or not even ICS. And then poor adherence to maintenance treatment, any incorrect inhaler technique. Patient have still smoker using e-cigarette vapor user. Patient we also have to um, ask the patient regarding their comorbidities, any obesity, any GERD symptoms, where the patient having chronic allergic rhinitis or confirmed food allergy. Patient in pregnancy also having risk for future exacerbation, or whether they have type 2 inflammatory markers, which is high FeNO or high blood eosinophilia. Like I mentioned just now, for lung function test, if patient having low FEV1, especially less than 60% predicted, and if the patient has high bronchodilator responsiveness. So currently we proceed to management of stable asthma. Stable asthma, basically you can categorize into mild, moderate, and severe. For mild stable asthma, basically this asthma that well controlled on low intensity treatment, whereas for moderate, the asthma is well controlled on low or medium dose ICS LABA, and for the severe asthma, it is controlled asthma on high dose ICS LABA treatment. However, it worsens when high dose treatment is reduced, or it also can be defined as uncontrolled asthma despite adherence to maximal optimized high-dose ICS LABA and management of their contributory factors. So before we before we initiate the treatment for the patient, our asthma patient, we must familiarize ourselves with with the inhalers, especially those that are available in our facility. What is SABA that is available in our facility, ICS, ICS LABA, or any other um, inhalers that we can use in treatment of asthma. So before we proceed with the initiation of the treatment of asthma, we must also aware regarding the categorization of the ICS dose, because in the management of the asthma, there's mention about low ICS dose, medium ICS dose, and high ICS dose, depends on which ICS that we are using in that patient. So what are treatment goals that we aiming for our asthmatic patient? First, we want them to achieve optimal asthma control, and then we want to minimize the risk for future exacerbation. We want to reduce the side effect from the treatment as well. We want to prevent the persistent airflow limitation and lowering the asthma related morbidity. So this is what I mentioned just now. Once we confirm the diagnosis of asthma, we can initiate the asthma treatment. But after the confirmation of asthma, we need to assess for the asthma control by evaluating their current symptoms, whether they have well-controlled asthma or not. If they have a well-controlled asthma, then we can confidently start them on maintenance low-dose ICS plus PRN SABA, or PRN ICS formoterol, or PRN ICS SABA. And then we need to reassess the asthma symptoms within 3 to 6 months. If they have not, if their asthma is not well controlled, it depends whether their symptoms, most of the days having symptoms, or night awakening more or equals to 1 week, or FEV1 less than 80% of predicted or lower limit normal, then we can start them on maintenance low-dose ICS LABA or low to medium dose ICS. If patient having daily symptoms or nighttime awakening more or equals to 1 a week, or FEV1 less than 80% of predicted or lower limit normal, then we can start them on maintenance medium to high dose ICS LABA, or medium dose ICS LABA with add-on LAMA. This is basically for the maintenance. Then we must start them on reliever as well. Are they using SABA or ICS SABA or ICS formoterol? If we already prescribe patient with ICS formoterol, the reliever is the same for them. So after we start the patient on treatment of asthma, we need to reassess within 1 to 3 months, so that we can consider stepping up the treatment or stepping down the treatment. For step up treatment, we must ensure that patient is already compliant to current medication. We assess their MDI technique, and we also address the modifiable risk factors. If symptoms still uncontrolled or still having exacerbation despite on medication for 2 to 3 months, we must consider step up the treatment. Or after we review, this one is what we call sustained step up, which is we only step up the treatment during our medical review. Other option, we also can use short-term step up in case if any exacerbation, a step up done 1 to 2 weeks with guidance from the written asthma action plan. So during review, we also can consider stepping down the treatment. So before we are doing step down treatment, we must ensure that the step down is taking in appropriate time, not during the infection, during pregnancy, or during travel. And during this time, we must educate patients to document their asthma control and teach them regarding written asthma action plan. So if symptoms already controlled for more than 3 months and the patient having low risk for exacerbation, we aim to find the lowest effective dose to minimize the side effect from the treatment itself. So we can try to reduce 20 to 50% of ICS dose every 3 months interval. Other than that, those patients with well-controlled asthma for 3 to 6 months, as I mentioned before, we can consider for step-down treatment. Other factors to accept before step-down: FEV1 percentage predicted must be more or equals to 80% and any absence of asthma exacerbation in the last 1 year. So this is the algorithm provided in our local CPG, how to do step up and step down option in management of stable asthma. Basically for the reliever is maintained whether we are using ICS formoterol or we are using ICS SABA or SABA itself. For the ICS formoterol, the maximum total dose is 12 puff per day, including the maintenance therapy. So for maintenance, this is the one that we must consider to do step up or step down treatment for the patient. Depends on their asthma control, depends on their future exacerbation risk and their adherence to the treatment. So what are the evidence from the network meta-analysis? For mild to moderate asthma, it's found that low dose maintenance and reliever therapy are equally effective compared to ICS LABA PRN. For low dose mild is significantly more effective than ICS LABA with as needed SABA and ICS with as needed SABA. For moderate to severe asthma, it is found that low to medium dose MAT is equally effective to high dose ICS LABA with as needed SABA, and low to medium dose MAT more or significantly effective compared to low to medium dose ICS LABA with as needed SABA or ICS with as needed SABA. As I mentioned just now, one of the option treatment available is ICS formoterol. So I would like to share to you how we can use the Symbicort turbohaler, and this video is highlight on how to the technique on using Symbicort.
Hi there! You have logged into this video because your doctor has just prescribed you with Symbicort. Let me show you how to use the Symbicort turbohaler device. It's as easy as twist, click, and inhale. Firstly, unscrew and lift off the turbohaler cap. Then, you can load the dose by twisting the red grip of the turbohaler until you hear a click sound. Just make sure that you are holding the turbohaler upright while you are doing this. The turbohaler needs to be in an upright position to ensure that the loaded dose is exactly what you need for future use. If you are using a new Symbicort turbohaler, prime the new unit by clicking twice before inhaling from it, like this. Twist and click, followed by the second twist and click. Your new turbohaler is now primed. Before your first inhalation, twist and click the turbohaler. Your new turbohaler is now ready to be used. It is important to empty your lungs prior to inhaling your medication. Exhale deeply through your mouth. Put the mouthpiece between your teeth and seal tightly with your mouth. Then, inhale as deeply and forcefully as you can through your mouth. Repeat this entire process if you need to inhale another dose. Now, try the whole process together with me. If you have inhaled from the turbohaler, but wondering whether you had done it properly because you did not feel anything, here's an easy test you can do to see if you are doing it right. You can test this out by covering a black cloth over the Symbicort turbohaler mouthpiece. After loading the dose and inhaling, remove the black cloth and you will see small white spots of the medication on the side of the cloth covering the mouthpiece. The amount of drug required is little. You can see that there is drug upon inhalation going directly into your lung. After that, it is important to screw the cap tightly back on. Don't forget to gargle and rinse your mouth with water after taking your dose. The Symbicort turbohaler has a dose counter at every 10 doses, which shows the remaining doses left. When the indicator turns red, it means that it is time to get a new turbuhaler. When the indicator turns 0, it means it is time to use a new turbuhaler. Don't wait until you finish your medication to get your refill. Get a new turbuhaler when the indicator turns red. And remember, take your medication as instructed by your doctor, and follow up with your doctor with the appointment set. It's great sharing this with you. Now, wasn't that easy?
Okay. Moving forward to continue with our my presentation today, proceed with patient education and skill training. So for patient education, we during our medical review, we basically must educate the patient regarding the asthma disease. Mainly, we must touch regarding the pathophysiology, the natural history of asthma. We must mention to our patient what are maintenance and what are the reliever therapy that we must use in asthma, and how these two can help in asthma symptoms. We must teach them what is important in the management of asthma. Not only the reliever that have that not only the reliever that can help in manage the asthma symptoms, but the maintenance is the must and the main important treatment. Main important treatment. Other than that, we can educate the patient regarding the asthma action plan so that they can act accordingly depending on the asthma symptoms. We also must assess their inhaler technique. So as a doctor, we must familiarize ourselves with all the inhalers technique that that are available in our primary care or our facilities, so that once the patient already step up treatment or step down treatment, they are using different inhalers, so we can assess their technique correctly. This is important to promote health literacy to improve adherence and asthma control in our patient. As mentioned over here, that it's found that self-monitoring either using PEFR or symptoms with regular medical review and written asthma action plan can basically reduce the emergency hospital visit and hospitalization rate. So this is the suggested asthma action plan template. For this one, if patient using the reliever, either using SABA or ICS SABA. So in this one, if patient having the asthma is well controlled, so they no need to use the reliever except if they have exercise-induced asthma. If the patient's symptoms getting worse, they need to take 2 to 4 inhalation every 20 minutes for a total 3 times and assess back symptoms. If symptoms improve or PEFR improve, so they can lengthen the interval to every 3 to 4 hours as needed. And duration may be further lengthened based on continued and good response. If symptoms worsen, so they must proceed to alert management, in which they must get the treatment from the health professional. This is another asthma action plan, but in this asthma action plan, patient is using MAT therapy or maintenance and reliever therapy, meaning that patient is using a single inhalers. So for this one, an example, if patient using ICS formoterol for both controller and reliever, she must take 1 inhalation as needed to reduce the symptoms, and the maximum 12 inhalation per day, including the controller dose. If the symptoms is worsened or persist, must proceed to alert management, so that they must go to the nearest hospital or clinic. Okay, so we already start the pharmacological treatment for the patient. We do not forget the non-pharmacological aspect. We must ask the patient, for those patients who are still smoking despite having asthma, we must strongly advise them to stop smoking, because this can first exacerbate the symptoms, and this is also one of the risk factor for future exacerbation. For those patients who are obese, we must advise them for weight reduction so that they can have a better asthma control. And then we must ask the patient to actively doing exercise, including the yoga. Not to forget that we can advise patient to get extra vaccination, and another important things, if their asthma is triggered by any presence of allergens or triggering factor, they must avoid those. So for vaccination, in our local CPG, it's mentioned that for influenza vaccination, it is encouraged for them to receive influenza vaccination. However, for pneumococcal, there's inadequate evidence to recommend the routine use of pneumococcal vaccination unless for those who require maintenance corticosteroid or repeated systemic corticosteroid therapy. So, how do we follow up patient with asthma? Usually, patient with scheduled visit are suggested as follow. Those who have exacerbation, we must review them within 1 to 2 weeks. After we start the treatment, like I mentioned before, we must review within 1 to 3 months to see whether we need to step up or step down the treatment. Once patient stable, once patients already stable, we must review them every 3 to 6 months. And in pregnancy, we must have quite a regular visit every 4 to 6 weeks. Okay, this is mainly summarize what I'm presented earlier, in which during a medical review, we need to assess the patient, confirm the diagnosis of asthma. We ask regarding the symptoms control and risk factor, including their lung function test, and we assess their inhaler technique and adherence to treatment, and what are patient preference in managing the asthma. So after we assess the patient, we need to adjust the treatment, in which we treat the modifiable risk factors and their comorbidities to with our target in mind to control the asthma as well. We educate and do the skills training like I mentioned before, and we also cover for non-pharmacological strategies for the patient, and we advise advise on asthma medication. So after that, we must review their response in terms of the symptoms, their exacerbation risk, any side effect from the treatment, and we assess their lung function test and how patient satisfaction after we start the treatment. So when we supposed to refer patient to chest team or respiratory specialist team. First we must refer if the diagnosis of asthma is not clear. Once we suspected occupational asthma, once those patients who have poor response to asthma treatment, patient with persistent symptoms despite continuous use of moderate to high dose ICS combined with long-acting beta-2 agonist, patient with severe or life-threatening asthma exacerbation, asthma in pregnancy, usually those who are uncontrolled, and asthma with multiple comorbidities. We're moving on to the asthma in a special group. First, asthma during pregnancy. Basically, in asthma in pregnancy is natural history of asthma in pregnancy is variable. The approach to diagnosis always is almost similar to for non-pregnant asthma, and you must remember that chest radiography is not contraindicated. Once there's indication for patient to proceed with chest X-ray, we can proceed, and this is not contraindicated. For the pregnancy with asthma, there are possible mechanisms that involve, because in asthma, there are about three there are risks to get the changes is asthma severity in pregnant patient. One third of them having will see that their asthma symptoms will get worse. One third of them will see that their asthma remains the same, and one third of them will see their asthma symptoms improve. So what are management of asthma in pregnancy? Basically, the management of asthma in pregnancy is almost the same for as for non-pregnant patient, and the ICS being the preferred long-term controller medication. The those patient asthmatic patient in pregnancy, uh, we must educate patient on good asthma control. And like I mentioned just now, we must do frequent monitoring 4 to 6 weeks to review the asthma control. And then for the treatment, maintenance, reliever, and if patient on anti-leukotriene, we must continue the treatment. Stepping down medication should not be done during the pregnancy. We only consider stepping down medication after delivery, even if asthma is well controlled. For biologics, for asthma, we only can, this one should be considered only when benefit outweigh risk after consultation with specialists. Asthma exacerbation during pregnancy, we must give a prompt treatment basically to avoid fetal hypoxia. And the management is almost the same with non-pregnant patient, in which we manage them with oxygen. We give inhaled beta agonist, and sometimes we can proceed with giving inhaled anticholinergic as well, and possibly giving systemic corticosteroid. During breastfeeding, the medication is continued normally. So how about occupational asthma? This is a form of work-related asthma caused by specific workplace exposure and triggered by immunologic or non-immunologic airborne stimuli present in the workplace. So this one we can diagnose when we see there's a variability of more or equals to 20% on work days compared to off days, which is non-work days, is suggestive of work-related asthma. Patient with suspected occupational asthma, this one should be referred to a specialist for further evaluation, and confirmed cases of OA should be notified and reported to the Department of Occupational Safety and Health. So this is what I mentioned just now. Once we want to diagnose occupational asthma, we must see that there is a variability of more or equals to 20% on work days compared to off days, and this is how we calculate and get the variability. First, a patient must record the PEFR reading. Patient must calculate daily variability for each day, find the highest and lowest PEFR reading, and then we calculate the daily variability using the formula, the highest PEFR minus lower PEFR, and then divide by means PEFR of the day times 100, and we can get the variability for day one. And this one, after that, we calculate the mean workday variability and mean non-workday variability. Then we calculate the difference between work-related variability. Work-related variability we can get from mean workday variability minus the mean non-workday variability, and we can get the answer. Those is more or equals 20% on work days compared to off days, suggestive of work-related asthma or occupational asthma. So moving on to exercise-induced bronchoconstriction, 10% of general population and about 90% of patients with asthma having exercise-induced bronchoconstriction. This is mainly the symptoms occur during or after strenuous exercise and usually peak 5 to 10 minutes after exercise. For those 10% who have doesn't have asthma, sometimes we need to do the clinical or the exercise or surrogate challenge test to diagnose. And the treatment for exercise-induced bronchoconstriction, we can give ICS SABA 15 to 20 minutes before exercise. This mainly for non-asthmatic exercise-induced bronchoconstriction, or we give ICS SABA or low-dose ICS formoterol as needed, and warm up before exercise. So we come to the end of my presentation. My take-home message for today: all asthmatic patients must be on ICS. ICS LABA is preferred over high-dose ICS because we must consider the side effect of the inhaled corticosteroid as well. Asthma patients should strongly encourage to stop smoking. SABA overuse should be avoided. And the last one, LABA without ICS should not be used as reliever monotherapy. So for information to others, currently spirometry test is now available at our Iium Family Health Clinic, and you can get the spirometry test done for your patient in 1 week. Just contact our FSC at this number to get their appointment for the spirometry. I think that's all from me. Thank you.
All right, thank you very much, Dr. Zam, for the very concise presentation. I think that's a very good presentation, quite on time lah anyway. So I think Dr. Zam already highlighted to us the recommended based on our locally made CPG. I know we have GINA every year for asthma. Asthma is very yearly updated, but I believe there's no, our locally made guideline is still probably the best that we can have lah, and it's because of locally made and locally adapted, yeah. So with regard to our accessibility and so on. All right. Also, I think if you can see now the algorithm, right, also different compared to what Gina highlighted, thread 1 and thread 2. We have our own locally made algorithm as well. Hopefully, we can follow that as much as possible. And then also, all right. So we have question. We have question. I think we have one question. In the presentation, you stated term stable asthma into mild, moderate, and severe. Is there a category for unstable asthma, right? Probably a bit confusing just now. But in our CPG, there's no term used as unstable asthma. Yeah? So basically, stable asthma is referred to patient that you saw every day in your clinic, lah, come for regular follow-up. That is stable asthma. So the management just now is for that stable asthma. You also have other term like exacerbation. That's different story. That's different algorithm. We also have term like difficult to treat asthma and severe asthma. That's usually we already call out our chest or respiratory team to help us. So most of the time it's stable asthma. All right, there's no term of unstable asthma. I hope that answered the question. For the treatment for exercise-induced bronchoconstriction, is it the same for asthmatic and non-asthmatic? Quite different actually. For non-asthmatic, we can use SABA alone. Yeah, we can use SABA alone before the what we call before the exercise happen. But for asthmatic patient, we should use SABA plus ICS. Never forget about the ICS as well. All right. So for non-asthma, SABA alone. For asthma, ICS and SABA before the exercise. Of course, the other things remain the same. For example, graded exercise, warming up before exercise, and so on. That's something that we can do as normal lah, as usual, similar. All right. Cancer attack use as MAT therapy. We actually for MAT therapy we use the fast acting. We have SABA and LABA, short acting and long acting. But under LABA we have so-called, some people name it FABA, fast acting. So it's long but fast onset or rapid onset. So for MAT we usually use formoterol, which is LABA with rapid onset. So we didn't include serotype as part of the MAT therapy. So MAT therapy should use ICS plus formoterol, be it budesonide or beclomethasone. But it should be formoterol because it has rapid or fast onset. Some people call it as FABA. All right, fast action. Okay, any other question? Inside the chat box, I don't see anything.
Assalamualaikum, Dr. Adi.
Alhamdulillah, siapa tu?
Azwanis here.
Yes, Prof. Azwanis.
Discussing this book. I just want to ask, as you mentioned in the slides, that we have to use ICS, which is SABA, for the traditional punya method lah, not the MAT therapy, right? So each time that we use the SABA, we must have one puff of ICS as well, right? Because now it's combination. But in terms of say that they have emergency and it's asthma action plan, right? And they have to use it quite frequent, every 20 minutes. Does that SABA need to be with ICS as well? And can you just explain macam mana how do we ask patient, how do we demonstrate to patient? You puff one and then you take the other canister and you puff after that, is it? I
So
know
that's
we're
why you want to
moving
share again?
towards,
The slide.
I think we're moving towards smart therapy lah, but there are still some patients who still on the traditional NDIs. Thank you.
All right. Thank you, Dr. Zwanis. Dr. Zwanis. Dr. Zwan, you want to share again the slide just now? Dr. Zwan, you want to share again the slide just now? I think it's about the asthma action plan, right? Okay, go on. Dr. Zwan, you want to say anything about this? With regard to both Azwani's question just now?
I think from the asthma action plan, this one only mentioned over here that we use the reliever. So we are just using Sabah lah not it doesn't mention over here to use ICSL as well.
All right. So
because
okay, go on. Dr. Zwan, want to add?
because there is part for controller, which is this one for ICS, and then there's a part of reliever. So in terms of during asthma action plan, for we just the changes is only in the reliever part, which is Sabah lah. Is it correct?
All right. All right. All right. There are two things here. Number one is very important to determine your patient is already on regular ICS or not. All right. So there are two things, whether we are using ICS plus Sabah PRN or ICS regular but Sabah PRN. The aim is to avoid regular Sabah monotherapy. That's the aim, the main aim inside the CPG is to prevent regular Sabah monotherapy. All right. So if your patient already have regular ICS, for example, then you can use Sabah alone. But if you're using PRN basis, ICS plus Sabah, then every time you use Sabah, yes, we have to use ICS. All right, so for PRN, you have to use. But again, for this kind of patient that using PRN basis, but keep on using salbutamol as well as ICS together, you must assess again the control and you must probably put this patient on regular ICS. On regular ICS, then you can use Sabah as available. All right, that's why there are three terms there in the, can you show the apa nama tu, the algorithm, Dr. Zam?
Yeah, is it?
This one, the other one is, okay. No, the other one.
This one.
Yeah, this one. So you can see three things here as reliever, right? One is ICS formoterol, ICS Sabah or Sabah only. So for Sabah only is for those yang regular ICS already. But for ICS Sabah is for those not on regular ICS, but they are using PRN basis, Sabah plus ICS. So every time they use Sabah, they should use ICS. But again, I remind, for this kind of patient, you must assess again the control and probably have to step up on using regular ICS. All right. Okay, Professor Anis. Also, we got to the how do you show just now? How do you show the patient, right? On the use of course, you have to use separately lah, one by one. All right, you have to separately use Sabah first and then ICS.
If they use apa tu what's that thing? Aero chamber, can they mix everything in one?
No, cannot. Definitely cannot. Right? It has to be one by one. Even if they, let's say, very severe asthma, very severe asthma, they cannot use like 6 puffs in a way and just straight away blow. No, cannot. They cannot. One by a time, at least 30 seconds, for example, in between. All right. They have to go at least 5 to 6 tidal breath, normal tidal breath, for each puff inside the spacer. Assalamualaikum, Doctor. My name is Zamir. Okay, Zamir, hi. Based on ARS, ATS, that score can be used to assess severity of asthma. May I explain on that? Thank you, Doctor. All right, we have scoring. Yeah? If you do patient on spirometry, we have scoring. For example, the 70% is, I can't remember the numbers exactly. Hold on, let me check. Yes, even our machine, our spirometry machine, we have, for example, mild is more than 70% of everyone. Moderate is 60 to 69. And then below that is moderately severe, and then severe is below 50%, and very severe is below 35%. This is very important, yeah. When you do spirometry for a patient, based on FEV1, the ATS and ARS can determine the degree of severity. For example, if you want to step down, for those less than 60%, for example, I don't think it's good to step down, although the patient might claim the symptom is good control, but I think we should also have our objective measure, which is using spirometry. All right, so like I mentioned for Dr. Jasmine just now, is based on the FEV1 percentage, which is if mild, more than 70%, and moderate is 60 to 69, moderate is severe 50 to 59, and severe is less than 50%. Based on that. And if let's say those from clinic side, you refer to us for spirometry, we also provide that one. So you can use that as a guide also. One of the questions that quite popular during the training of trainers CPG asthma is that can we diagnose patient with asthma without spirometry? Yeah? So the answer is definitely yes, you can, no problem. At the end of the day, what matters most is your history taking, your clinical assessment. But if you at any time have access to spiro, please do it. Even though you already start patient on ICS, but please also still you can do it spirometry. My experience is most patients, although they are already on ICS, if they are really truly asthma, they still show the reversibility test of 5% or more. All right. So yes, please do, and not just for confirmed diagnosis, but also for to see the response to ICS 3 to 6 months later, as well as annually. One of the target during the TOT-CPG mention is that we hope every clinic we have spirometry just like we have ECG. So that's highlight the importance of spirometry. All right. So I think, Salam doctor, how to define patient is on high or low dose of steroid inhaler? This one is depend on your dose equivalent. Yeah? You have to refer to the one of the page inside the CPG. I can't remember. I'm not working CPG. So yeah, page 27. Categorization of ICS doses, table 7. You can refer to that. All right. So whether you're using budesonide or beclomethasone, for example, if you use Symbicort ICS.
Sorry, Dr. Hadi.
Yes.
T1 is for the Symbicort, not steroid.
Oh, same again. If it's Symbicort, same again, because you also have steroid inside that. For Symbicort, we have budesonide inside that. So you have to refer to budesonide dose. All right. If you inside the table 7, it's number 3, row number 3, budesonide. All right. So you have to look at the preparation of Symbicort. How much, for example, we use 160, right? Budesonide. So if 160, if you use 2 PAF, BD, for example, 160 times 2 is 320, times another 2 is 640. 640 already moderate medium dose of ICS. So that's the answer. Yeah, this table. All right. So focus on budesonide if you are using Symbicort. If you're using Foster, focus on the beclomethasone because it depends on what ICS available inside that medication. Okay, Dr. Shazwan. All right. Is there any question before we end? If no, I think thank you very much for the discussion. So again, if you don't have yet spirometry in your clinic, come and refer to us. We provide the result within 1 week. Hopefully, it can help our patient to improve better in terms of their asthma control. They are still okay. Right. Okay. Right. That's the link for CME for CPD. Right. Thank you very much, everyone. Thank you very much, Dr. Zam, for the presentation. Hope it benefit everyone. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.